picture like a character who has and embodies anxiety, it's 100% going to be Piglet, right? From Winnie the Pooh. Like, he is a very good representation of what a person who is anxious looks like, right? He's always worried. He kind of gets overwhelmed pretty easy. He's always kind of focusing on what's going to come next. He's always kind of has that anticipatory anxiety that's coming out, right? And then when you look at him, he also sometimes appears kind of weak, sits towards the back. Again, somebody who is anxious, they're easily overwhelmed, right? And a lot of times they have such a great fear about what's about to happen that they either never go through with that action, or and when they do, it's exhausting for them. They'll sit towards the back, right? They'll avoid the groups, avoid the crowds. A lot of times they're kind of sitting hunched over in the corner. And if your anxiety is bad enough, it can actually start to represent itself in the physical form where now that patient is complaining about a lot of pain, but there's no real good reason or diagnosis for it. A lot of times that's anxiety, right? Especially when we're talking about back pain, neck pain, migraines, and things like that. One of the best referrals I've ever gotten was from a physical therapist who got sent over by primary care, pretty good history of just vague, non-specific low back pain. And the physical therapist at their initial encounter did a GAD-7 on him, and I was like, hey, I think you have anxiety. And sent them over to us. We were actually able to get them under control, get their anxiety fixed, and all of a sudden their back pain cleared up, right? That's how overwhelmed and anxious they were. Another thing, anxiety is not necessarily bad. Anxiety is what encourages us to prepare, right? If you weren't anxious about your next test that was coming up, you wouldn't bother studying for it, right? And then if you fail, that would be on you. Anxiety can be a good thing. It forces us to prepare, to get ready, but now it's become a disorder when that becomes the predominant portion of your life. And we all have experience with anxiety. A great example for you all is just think about how you feel about one of those tests you know is going to be a rough one, right? Pharmacology or something like that. That moment before you go into that test and you're sitting in your chair, kind of overwhelmed, your heart's starting to flutter, race, maybe you're getting some pain in your hands, your neck. That is anxiety. That is a performance anxiety, right? So we all have experience with that. You know what it feels like. Cool. So let's get into it. I'll show you that. So anxiety, when you're talking about screener forms are great. They can offer help with doing something very, very quickly. Just realize the screener form, you always have to go back and interpret that. You don't diagnose off of the screener form. For us, the biggest one you're going to see is the GAD-7. And it starts off as the GAD-2. That's your initial 2 questions. If you screen positive on that, you go in and you give them the GAD-7. It's a really good screener, but it's only specific for generalized anxiety disorder, right? And of course, as with everything in psychiatry, we're never the number 1, number 2 diagnosis, right? You have to rule out all that organic etiology first. But no matter what, we're always going to be number 4, number 5 in your differential list when you're talking about possible diagnoses. You have to rule out everything else first, right? There's your GAD-7. You'll use these a lot in your clinical practice. I may give you a GAD-7 number in the test question, but I'm never going to ask you, like, hey, interpret this form and tell me what their score is, right? But I may give it as part of the scenario, so it can be helpful to know what's mild, moderate, and severe, but I'm not going to test you on that portion. Okay? It's important to differentiate fear versus anxiety. Fear is that immediate threat, and anxiety can present as fear. Whereas it can be in there as one of the things they're worried about, but there is a difference between fear and anxiety. That's kind of all those symptoms that we were talking about. Well, again, a lot of you all probably experience this as well. And what you'll see when we do the trauma disorders, there's a lot of overlap between anxiety and trauma. A lot of the same symptoms are going to be popping up. And there's a reason for that we'll talk about in the next lecture. So anxiety disorders, when you're thinking about how to differentiate these, because they're all going to sound very, very similar, What it comes down to is what is causing the anxiety. If they have a fear of public speaking, well, now we have a very specific condition, and that's going to be performance anxiety, right? If they have a fear about going outside, well, now that becomes agoraphobia. If they have a fear about or an anxiety about all these different things, they're worried about their finances, they're worried about their relationship, they're worried about work. Well, now that's just generally afraid of everything or anxiety about everything. That becomes generalized anxiety disorder. If they have a fear of snakes, a fear of heights, right, a fear of claustrophobia, now that is a specific anxiety, so that's going to be a specific phobia, right? So when you're thinking about these, they all present relatively the same. You have to identify what is causing it, and that's what you're going to use for your diagnosis. Anxiety disorders, these are the ones we're going to talk about right here. These ones we're not going to talk about, but just recognize that there's more to the story than just the ones we're having. You can be diagnosed with a lot of these. Separation anxiety, that happens a lot in kids, and it can actually carry forward into adulthood. Selective mutism, again, that tends to be in adolescents, kids when they go to school, and that's where you just don't talk in public, right? That was the kid who sat in the back of the classroom and never engaged with anybody. A lot of times people will think that they have a learning disability, maybe they're intellectually dysfunctional, when in reality, their intelligence is still there. They just don't feel comfortable. They don't want to engage with the group, right? Panic attack specifier. I'm not really going to test you guys on specifiers, but this is one, just realize there is a difference between a panic attack and panic disorder. Panic attack is a specifier that you can add on to generalized anxiety disorder, social anxiety disorder. So when somebody has overwhelming heart racing, feel like they're having a heart attack and they go to the ER, they don't necessarily have a panic disorder. You can add on the specifier to panic attacks, right? So there is a difference between the two. Not everything is panic disorder. It's a very unique disorder. Right? Separation anxiety, these are just kind of a catch-all, just to give you guys some background info about them. Again, this tends to be in kids. That's the kid who never wants to separate from their mom or their dad. They can't just be like that normally. That can't just be their temperament, or it could be something that happened, right? A lot of times if it's the death of a parent or an accident happened to the parent, now that child becomes very clingy because what has happened. You see this a lot in kids that are recovering from abuse and neglect, right? That's kind of what happened to them. Okay. Specific phobias. So these are the ones where you have a specific phobia about a thing, right? Classic one being like claustrophobia, fear of heights, fear of spiders, fear of snakes. It's always linked back into something very, very specific. That's how we're able to separate this disorder out, right? And when you're thinking about treatment for these, really the mainstay of treatment is going to be therapy if that patient actually wants to work on themselves. If they have a fear of airplanes and they're perfectly happy just taking the bus and the car everywhere, good luck getting them into therapy. They think they don't need it, right? Another good one is claustrophobia. When your patients are going for the MRIs that you're going to order, let's say you need an MRI of the knee, MRI of the back, they have to be able to sit in that machine for 45 minutes, 50 minutes, right? But the average person is only going to get maybe 3 or 4 MRIs in their lifetime. You could send them to therapy for that. Therapy can be very intensive and it's long, or you just give them a situational med, have them go get their MRI done, and they carry on honky-dory with the rest of their life, right? So treatment's always going to be therapy, but it's very situational. A lot of times we use the meds. Okay. So that's going to be your basic info. So this has to be a fear or anxiety that's out of proportion to what actually is going on. You always want to keep that in mind. 6 months when we're talking about anxiety disorders, that tends to be our cutoff. We always want these signs and symptoms to be present for at least or greater than 6 months. That's pretty much the standard for most of the anxiety disorders. There might be 1 or 2, especially when you're dealing with kids, that's a little bit shorter just because we always have a shorter time frame for them. So there's your pink box criteria. Again, I'm not going to read that to you all, but if you want kind of that deeper dive into what's going on, the pink box is there for you all to kind of read through and get an idea. And I'm not going to test you on the specific names of all of these phobic disorders. I'm not going to tell you like, hey, identify arachnophobia or something like that. but just realize in that scenario, paint a picture of someone who's afraid of something, and then you say, oh, this is a specific phobia, or it will be the treatment of it, right? Good. First line therapy, what we talked about, caution. One kind of word of caution, when you're talking about the specific therapies, just from a test writing perspective and test taker perspective, realize in this section and trauma section, there are some specific therapies that are unique to these conditions. So CBT is not necessarily the answer for all of these conditions. So make sure you don't make that mistake and just click CBT for all of these. Actually read through and make sure you understand which ones were a go with which disorder, right? Medications, propranolol is a great med. I use it a lot, especially for like performance anxiety, specific phobias. It drops that heart rate down, kind of lessens those vagus nerve and all of that stuff. It's a good med, but you can bottom somebody out, especially if they're on a bunch of other cardiac meds, right? Because it is a beta blocker. Benzos, I actually don't have a problem with using benzos in these patients because they work really, really well. It's a very effective med. People love it. That's why it becomes a drug of abuse. If you're going to select a benzo, remember, we want a long-acting benzodiazepine. We don't want short-acting. Short-acting increases that risk for addiction. And just kind of, I'll hop on a soapbox here for a second. Do not prescribe Xanax, right? Patients love Xanax. They love their Xannies. Do not prescribe them. Trust me, don't make that mistake. I've made that before. If you're going to use a benzo, use a Valium, use one of those long-acting ones, right? And then make sure they have somebody who's able to drive them because you are using that long-acting. Xanax, they love to prescribe it. It's starting to fall out of favor, but you'll still see it a lot on the civilian side. What will happen with Xanax is it's so short-acting that when it disappears, their anxiety becomes roaring back, so they take another. And then it drops, and the anxiety comes roaring back, so they take another. And now all of a sudden, that 30-day supply is gone within 1 or 2 weeks. And now, when they come off of that Xanax, they actually are going to have worsening anxiety because they're craving that medication. It actually makes their anxiety worse. So I'll hop off my soapbox about that. So if you're going to use benzo, long term, right? And again, if we have the option, combo is always going to be better. The therapy teaches them lifelong skills. The medication gets a hold of it in the short term, okay? Social anxiety disorder, again, if you're thinking about this one, this is that fear of interacting with a group or in public, right? That's what's going to cause your social anxiety. So giving a speech, having a conversation, giving a speech, it can be that fear of public speaking, or that can go more into performance anxiety, but either way. Being observed, eating or drinking, you see that quite a bit, right? The biggest thing is kind of, again, that specifier at the very top. It's always going to be a social situation. Other than that, they're perfectly fine. Right? So again, greater than 6 months is your big kind of time cutoff for this. And then, of course, that exposure to scrutiny by others, or always that fear of being observed by somebody else and how they're kind of being judged is what's causing that. There's your pink box for all of that. Again, it sounds very similar to all of these, so always kind of pay attention to what is the cause for it. Okay. Again, CBT is going to be your first line therapy, but we can also use systemic desensitization. So what that is basically, I just kind of expose it to you over time, right? In small little increments that bring you out in public. It takes time, it's work, but it can be very, very effective. It's basically stress inoculation is what we're doing, right? Good. SSRIs or SNRIs, they both work. Again, when we're talking about those drugs, they're still fair game. You need to pay attention to what the side effect profile is and match those side effects to the person, right? Sometimes we can get a good benefit from one of the side effects and maybe makes them sleepy, or if it gives them a little bit more energy and makes them awake, you can kind of tailor that to it. My one caution is I would not use Wellbutrin or bupropion in patients who have anxiety. That drug tends to be very exciting, so a lot of times if you're using that one, it's going to make their anxiety significantly worse. And then just kind of anecdotally, there's a certain subset of the population that when you give them Wellbutrin, they just kind of turn into an irritable asshole. I don't know why that is. But sometimes if you have a patient who's perfectly fine, and maybe they're stressful, but you give them Wellbutrin, and now all of a sudden they're like, yeah, my wife says I'm really mean lately. A lot of times it can actually just be the Wellbutrin that's causing that. Propranolol, propranolol, that's a good one. Gabapentin. Gabapentin is a good med. We use it off-label for a lot of different things. Just realize that one, it makes them super drowsy. So if you're going to use it, you give it at night. And then two, if you are using it during the day, you have to go lower doses because it makes them really sleepy, drowsy. It kind of causes some cognitive impairment, right? Also, long term, there's a lot of studies that are coming out now about gabapentin, and it's been associated. It's not a clear cut, it's not perfect, but there's an association between long-term gabapentin use and early onset dementias, right? So that's one of the things you need to warn your patient about. That's not going to take like one pill and then they develop Alzheimer's. But lifetime use of it, now there's an earlier onset of the dementias, especially if they have a lot of other risk factors associated with it. Always educate your patient and so that you can make a clear choice, right? Again, benzos, we talked about that. Long acting is always going to be the preferred. So panic disorder. Panic disorder is unique in that usually these patients are perfectly fine, and then it just starts out of the blue, out of nowhere. They just get these overwhelming attacks of anxiety that happen. A lot of times the first time it happens, they'll go to the ER because they think they're having a heart attack, right? And you're going to do your EKG, your lab work, and be like, oh no, everything's fine with you. That's where it can now become panic disorder, okay? And again, there's usually no obvious cause or trigger with this one. That's what kind of makes it unique and sets it apart. Happens out of the blue, and it'll happen very short, intense, and then it goes away. And it's very short, intense, and then it goes away. They'll have these spurts that happen over time. And then that last part down here, that's another kind of defining feature about it, is now all of a sudden they have a really bad anxiety about having another panic disorder, another panic attack, right? It's one of the things that will set it apart. They now have this anticipatory fear about having another panic disorder. So that's your criteria that you need for it. Again, you only need 4 of them, and there's a lot to pick from. Usually the heart rate is the one that I'll see. Sweating, trembling is another big one, and chest pain is another big one that you'll see. Depersonalization, derealization, it's very, very unique. I usually don't see that one. We'll talk about that. That tends to show up more when they also have a diagnosis of like PTSD or something along those lines. Nausea or abdominal discomfort, that one's usually a little bit too vague, and it's not going to trigger like them going to the hospital. It's usually these bigger ones up here that they're coming in for. All right. Here's your diagnostic criteria. So treatment for these, again, CBT is a good one. Relaxation training can also be another useful one. We actually try to teach somebody how to calm down and how to relax. Medications are, I would almost argue, are a must for these people, right? Usually to help get them under control quickly, I am going to start an SSRI. At the same time, I'm sending that referral into therapy. That's usually where I get the best bang for my buck when you're actually treating them. Because again, a lot of times they know therapy is going to work, but it takes time. So they want something that's going to be a little bit quicker to help, and that's where these meds can come in handy. So antidepressants, SSRIs, SNRIs, TCAs, again, those are all pretty good. We always start with the SSRIs because they have the best safety profile, they have the most efficacy behind them, and there's going to be less risk if they do overdose that something bad happens, right? TCAs, we're always worried about that overdose. Benzos, this is where it kind of gets into more of an art form when you're talking about psychiatric meds. So benzos, we kind of teach guys they're evil and you never use them, but they can, and very situational, they're very, very helpful. So the way I'll kind of approach this, because it takes 4 to 6 weeks to tell if an SSRI is going to work, right? But at the same time, they're having these really bad panic attacks. So I'll start them on their benzo, usually like Zoloft or Prozac or one of those. And at the same time, I'll give them about a 30-day supply of a benzo, right? Usually diazepam or Valium or something along those lines, lorazepam. And then I'll say like, hey, you're going to start this medication. We're going to get you up to an effective dose. I'm only giving you a 30-day supply of the benzodiazepines. I'm not giving you any more. If you lose them, not giving you a refill. If you burn through all of them, not giving you a refill. And I want you to take it when you start to feel those symptoms, right? What this does is it allows us to get control of your anxiety, gives time for the other medication to work, and it's going to bridge you over to the next one. And then, once we have that, we'll tinker with it and get you up to an effective dose, not tinker with it. Okay? And that's how I'll kind of use the two together. So even though you always have to be careful when you're using them, if they're used effectively in a responsible patient, they're an effective drug you can use. Propranolol, I find it's not as helpful because it doesn't give them that quick relief that they're going to need when they're having a really bad panic attack. But you can use those as well, especially if you're concerned about a patient who maybe has a substance abuse history, or if you're concerned that they're selling the drugs. That's where it can be helpful for them. Or if you look through the record and you're seeing that they're doctor shopping, a lot of times I'll go with the propranolol or an Atarax instead. Right? Agoraphobia. So this one is that person who really never leaves the house. Essentially, their anxiety has become so overwhelming now that they're just never leaving. They don't like public places. They don't like riding on transportation. They never really want to leave. And if they do have to leave, they're always taking somebody with them. That's how bad it can get for them. And again, with this one, 6 months is kind of what you're using for that. And otherwise, the big separator, or say, between this one and social anxiety disorder is this one is not necessarily that fear about people observing you, which you see a lot in social anxiety disorder. This is more that just fear of like large crowds and being out with other people in public. That's why they just stay at home and they're perfectly fine, right? That's kind of what separates the two of them, even though they kind of present very similar. And this is kind of like a differential when you're talking about them. Again, this is that person who's just always at house by themselves and perfectly happy in their house by themselves. But the moment they leave, it starts to cause a lot of problems. So there's the diagnostic criteria. Nothing too crazy with that. Good. So these patients, again, peer support groups are super helpful. That's where we get them in a group. It's hard with people with agoraphobia because they don't necessarily like being out in public. But getting them together, it helps, right? Knowing that there's other people that are struggling, other people that are going through the same stuff as you, that's really where you kind of can show that you're not alone. It can be very, very helpful. Medications, again, no real major change with the meds. The meds get super repetitive after a while. I only have maybe like 100 meds I pick from in the psychiatric world, right? So it's usually super easy to learn. It's just the art form is hard when you're talking about psych. Okay. There's your treatment. This is the fun comic. All right, so now we're talking about generalized anxiety disorder. This is the one that you guys are going to see a lot. Because these patients, they don't necessarily have a severe deficit in like their overall function. It's just they have a bunch of different things going on in their life, and now it's starting to become overwhelming. So this one, you see it as a slow burn that starts, and it gets out of control. And it has to be multiple different things. So it's not one specific event like social anxiety. It's not that fear of going outside, interacting in a public space like you would see with agoraphobia. It's not just this fear of having another anxiety attack that starts out of the blue, which is what you see with panic disorder. This is multiple different things occurring throughout their life, not just one singular event. A lot of times money is a big one, family interactions is another one, their work life are usually the big ones they're going to see, their peer groups, you all kind of see it start to bubble up. And when you're talking with them, it's going to be hard because they're going to tell you there's only one specific thing they're worried about. That's where you have to get this background history of them and talk with them and find out what else is going on in their life. So these ones can be a hard diagnosis to make just because they have so many different things going on. All right? So, like I said multiple times, that excessive worry about multiple things, that's what makes it general. Right. At least 3, again, that 6-month criteria, you're seeing that quite a bit in the anxiety slide deck, so make sure you keep that in mind. Again, that's your muscle tension, sleep disturbance, irritability, concentration deficits. This is where a diagnosis can be, the patients are hard, is because this sounds very similar to ADHD. And a lot of times these are patients who think that they have ADHD and all they need is their methamphetamine to fix them. And there's a lot of roadblock. And if you look at them and like, I don't think you have ADHD, I think you just have anxiety. And then you have to convince them that that is actually true, and that's where it goes difficult. That's why the screeners for ADHD, they don't necessarily work very well, because most of the people are going to self-identify as having difficulty with concentration, difficulty with sleep, irritability, which has this huge overlap. You also see this is a huge overlap in the next lecture with PTSD. So you'll see a lot of these same things pop up multiple times. That's why the diagnosis in real patients can be relatively difficult to make. Right. There's your diagnostic criteria. So just imagine how you feel before going into a test. That's essentially what somebody with anxiety disorder feels like. The preponderance of almost every single day, right? If you remember, another one when I'm talking with patients that I'll see a lot is this is a person who's sitting in bed and they can't fall asleep because they're essentially just running through everything that has to happen in the next day or happened in the previous day, and they're taking 3 or 4 hours to actually fall asleep. So when I'm talking with them, I'll get a good sleep history, and a lot of times we'll see that pop up where they're basically saying, like, yeah, I'm just running a reel in my head of everything that I need to do the next day. It's just preventing me from falling asleep. So you'll see that quite a bit with anxiety disorder, especially with generalized. All right. CBT is a great one. Relaxation therapy, yeah, it works. Again, combo tends to be where we get the best result from this. Yep.
So what is that? Efficacy can equal meds. What does that mean again?
That's basically saying that when you're talking about your efficacy for your beds, it's never 100%. It's really only about 50 to 60% depending on the person. That's where we say if we do relaxation training, it equals about 50 to 60% of efficacy or improvement in symptoms. So it's comparable to meds. That's what they're saying.
Compared to meds.
Comparable to, again, the problem with it is you have to be dedicated to the therapy. You have to believe that it works, and it takes time. It takes 8, 9, 10, 12 sessions before you really start getting some improvement. So if it's available and patients don't want to do a med, I'll use it. But if like we're super backed up, there's not a lot of resources available, I'll tell them like, hey, let's start with the medication, let's give it a shot. That way, as we're waiting for CBT to kick off, now we can start to get that improvement. Right, does that answer your question? Good question. Right? Good. And yeah, I'm doing good on time. Okay, so just kind of a quick summary of CBT. So the reason CBT is kind of like the mainstay of treatment for a lot of these different conditions is simply because it's a manualized therapy. So that means anybody who is trained in it, they're all taught the exact same way. So we don't get a lot of variation within the field when you're practicing CBT. A lot of the other therapies can be very individualized and it's hard to copy and repeat, right? The other good thing about CBT is it's your baseline. It teaches people a lot of basic adulting skills that they don't necessarily have, which is contributing to these conditions. It teaches them what a healthy coping mechanism is. It teaches them what a cognitive distortion is. So it kind of puts down that groundwork for these patients, and if they do it properly, now we can build off that. That's where we send them to the more in-depth or the more specialized therapies. That's why we always tend to start with CBT. The other benefit to this one is it has set workbooks that the patient is supposed to do. So it actually legitimately gives you homework that you're supposed to take home, you fill out, and then you bring it back. So it forces the patient to kind of do some work on their own, on themselves, and then they bring that work back and show you that they're actually doing something. So it gives us a lot of resources that are kind of standardized that we can use for a lot of different cases, and that's why it's become the mainstay of treatment. It's not necessarily the best, but it's easy to get into, and it works, and that's why we like to use it. There's other ones that can be better if it's very situational, especially when you're talking about like PTSD and some of the other conditions. All right, relaxation training. So medications, again, antidepressants, whichever one works, those tend to be the best, again, focusing on those side effect profiles. Benzos, like we talked about with that bridging, that's one of the few times I'll actually use benzos is with my anxiety disorders. Miscellaneous, so buspirone. Buspirone is a great medication to use as an adjunct for anxiety disorders. It's never going to be I'm never going to treat with buspirone alone. You always want to use it in combination with an SSRI, right? So just to help you guys be good clinicians, if you get an anxiety patient, start them on their SSRI or their SNRI, whichever one you like. I'm good with it. See how they respond, and if they still need that little extra or something to kind of help carry them throughout the day, add on buspirone or buspar. It's good because it allows them to take a dose during the day. The downside is it has to be 3 times a day. You can get away with 2 times a day if you're at a higher dose and the patient is pretty good, but in general it has to be 3 times. So a lot of times I'll use these in combination together, okay? A common mistake I'll see from the primary care side is they'll only use buspirone, and again, it's 3 times a day dosing. They don't have them at a high enough dose, and they don't have something that's more long-term, so they're not getting good control of anxiety, and a lot of times I'll stop it and switch them over. So for you all, if you're going to do it, use them together. That's where I get the best effect, right? Gabapentin, if they're having a lot of chronic pain and they're maybe having some sleep issues and they have a lot of other stuff going on, I'll use the gabapentin, giving my big dose at night and then small doses during the day is how I like to use that one. It's effective, it works. I like to use it when they have a lot of other conditions going on. That's really where I get the best bang for my buck with gabapentin, right? Propranolol, I don't use it as much just because it tends to bottom people out, especially if they have generalized anxiety disorder. So I tend to have more issues with it, but it's a good option. Another one that you guys will see a lot in the military side is hydroxyzine or Atarax, right? Reason being is because it's not a controlled substance. It's relatively benign. It's an antihistamine, right? We actually use it for allergy meds. So it's not going to affect their deployability. It kind of makes them a little bit sleepy, a little bit tired. It works relatively quick, but it has a shorter half-life than Benadryl. So you'll see that a lot used in the military setting. And it's a good med. I have a lot of good effect with that if the patient knows about it and knows what to expect. Yeah, Benadryl, you're looking at, once you take a Benadryl, you're talking like 12 hours, really, so they're going to be kind of tired, groggy, and sleepy. With hydroxyzine, it's really only about 6 hours, so I get less of that grogginess throughout the day when I'm using it, right? Also, with Benadryl, there's kind of this risk for like a hangover effect when you come off of it. It can make your headaches worse, can make your sleep worse when you stop it or you use it long term. I don't get that as much with hydroxyzine. Don't ever use it as a sleep aid. It's really not designed for that. I know a lot of people do, but it doesn't have good efficacy to support sleep disorders. Does that answer your question? Good. Yeah. Again, you guys are going to encounter anxiety a lot, so finding a good combo that works for you as a provider is going to be key to your practice. Okay. So again, there's your GAD-7. That's your screener. You guys are going to use this a lot. Again, I'm not going to test you on it and tell you to calculate a score, but I may give it to you as part of the clinical scenarios. Just kind of be aware of that. All right. Mild, this is kind of talking through mild, moderate, and severe. If I can get you guys to make an accurate diagnosis of generalized anxiety disorder, I'm good with that. Let behavioral health worry about the specifiers. If you're feeling really confident and you know what's going on, by all means, throw on the specifier and categorize it as mild, moderate, and severe. If you're feeling that way, I'm good with that too. It's not really going to affect treatment that much, whether it's severe or mild. We all kind of approach it the exact same way. We're going to give them an SSRI or an SNRI. We're going to send them to CBT, send them to therapy, right? We tend to approach it that exact same way. It's just sometimes we're going to be a little bit quicker with the referral if it's severe than if it's mild. Right? Good. That's really the only thing that's changing is that abortive medication when you're talking through it. One kind of caveat when we're talking about an anxiety disorder, usually we tend to associate suicide and suicide attempts with like depression and bipolar disorder. I've had multiple patients where their anxiety is so overwhelming that it's actually starting to present as depression because they just think they're never going to get better, they can't go out and go do anything, and it'll actually start to creep into that suicide realm. So when you're talking with a patient who has anxiety, especially if it's severe, make sure you're always screening and checking for that suicide risk and ask them what's going on. If you have a patient who's super depressed and you're not really able to find a good reason why, don't be afraid to screen them for anxiety. A lot of times we'll see dual diagnosis where they'll have both anxiety and depression diagnosed at the same time. So those two, they love to cohabitate together. So always be aware of it when you're screening for one. Just kind of do that due diligence and check for the other as well. I'm not going to write a test question like that. That's just to help you guys be good clinicians when you're out there actually practicing. All right. So pretty good time on that one. We're at 36 minutes. Any questions about anxiety disorders before we take our break and jump into the next one? Once, twice, 3 times. All right, cool. Let's take our 10-minute break, and then we'll do the next one.
It is. Oh, it's nice to not have the AC. Oh, it's super nice. I love it. It's nice to not have the AC on that. I also.
So when you talk about that,
My cold word is Central Texas is cold as hell.
I didn't think Texas got that cold when we were at work.
A few snow days that we got.
Not even, it was just like an hour.
Yeah, it's because of the wind. It gets windy for like stupid reasons. So you guys said so we're just waiting to get back to Jacksonville. But Chili's got one. Yeah, so it would be if she goes from Miami to April. Because first, well, she has to fly in for an orientation in March. But for one, it's dual enrollment because one school is going to give them the masters, so she's applying for the orientation to the master's for a week in March, and then by the orientation at the actual school will be the first one. So she'll basically leave and go down and get settled in. Bar break would probably be like it'll be late March. I was like, man, we started like last week. No, like because we started. May 22nd.
Because we reported April 13th. So then that means that they gave us like 2 weeks.
Oh no, we started May 5th. No, never.
I just remember we had a So yeah, so you might be in that time.
Yeah, well, she would leave like the beginning of April, so I might just like fly down and help her get settled.
No holidays, right?
Yeah, so I would just like fly down and get settled.
You could also just fly her down, fly her down, then you take the car.
Now that I think about it, I don't think they're going to make people actually show up to graduation. I think
it's her card. She can take that. It's not my card. And she would no, because she needs to go see your family first. So that would make no sense. But then she has to fly to Jacksonville to drive those Jacksonville to drive. Jacksonville.
Why do you think it's okay to have an AC when it's 43 degrees?
I don't care. But all her, like, she would probably set up like see her, be a repair for like a week or two, and then get settled in for school.
You'll be here.
Yeah.
Put a lot of work.
Friday.
I'm just gonna go ahead and put this on because I'm gonna wear it on my bike right away. Yeah, just go ahead and get ready. I'll be excited for the next one.
I guess. I guess that
Yeah.
I just like how he talks.
Entertaining, like very knowledgeable, everything. I personally like it.
Just on his name, Bo's truck.
Here they are. It's pretty easy. Like first line. You know about Ring 6?
I don't know how long the last or how thick they are.
That's a white hair. I hate that. I have to go dig through all our winter stuff. I know I am right by my
We have no class on Friday, so we don't get no class on Friday.
It's like going on the record.
It's all like that.
Stop it to the show. I know they're inspired.
It's down to like low runner.
On Friday.
I legit with the line.
You show up to the clinic.
They're gonna do what they do.
You didn't want a high five. You're stopping. Okay. You're stopping something happening. I was working on. And so he was working that, and they had just put in it's wood. But he's still ended up burning. I was like, we were out there. It's a very big corner. No box splitter at all.
I think they've gotten through the like the things of like the classes. So now like yeah, and like they have like max. I was surprised like I thought they were gonna pop that like all.
So we had three Patty Mac. So we had three.
So you know you can go.
Oh wow.
You can click a has a breakdown and like check the grade to see like what you if you work at school what you Oh, it was a Wi-Fi guy. Who did it? Cheap fashion.
And then tell me what it's for three.
Oh my lord. You're taking them with bags? Yeah. Called walking talkers.
So here she did a 9. Yeah. I mean, this is like decent.
It's
You're gonna get like electro mix.
I almost I did drop it. Luckily it didn't drop. Drop the tree on the fence. That sounds.
Got it.
Literally. The freaking Health on Shelf shit is now just like all over.
Okay, so we're
First.
talking, this lecture is trauma and other stress-related disorders. When you look at the DSM-5, if any of you will actually look at the book copy in the chapters, they purposely put this condition kind of towards the middle because it's the great mimicker. It shows up as a lot of other conditions, and it has a lot of overlap with a lot of the other ones. So it's always important when you're dealing with a person that you're thinking it's mostly like MDD or mostly anxiety disorder. Always kind of do that quick check and make sure you're not missing some sort of traumatic event that happened in the past that's actually causing a lot of these symptoms, right? When you're talking about these disorders, what sets them apart is it's always event driven. There's always a singular event which started and is now causing all of these symptoms. So with MDD, it was kind of like you're just depressed for some reason, you don't necessarily know why. With anxiety disorder, it's kind of anxiety starts and it's always linked into one condition or location or something like that. With these, the event happens first, and now all of their disorders come after that, right? So when you're looking at criteria, doing your research, always kind of keep that in mind. There has to be some sort of event that's triggering everything. So these are the ones we're going to talk about. So we're going to talk about PTSD, acute stress reaction, and adjustment disorder, right? What we're not going to talk about is the prolonged grief disorder because we've already covered that. I'm thinking I'm going to take that lecture and move it in under this just so that way it makes sense. It's not necessarily a reason why that lecture should be off by itself because it falls in this category. Disinhibited social engagement disorder, that is in kids, right? And we see that disorder in kids who a lot of times, 9 times out of 10, are coming from some sort of disadvantaged background. So essentially, this is the kid that was experiencing really bad neglect. This is the kid who was experiencing abuse in the household, right? Essentially, what it is, boiled down, is this is a child who's basically acting like an adult, even though they're only maybe 6 or 7, right? That's not a normal response for a 6 or 7-year-old. There's a person who's just going off with strangers for no real reason. They're super comfortable with strangers because of that bad stuff that has happened earlier on in their life. So this is kind of like your catch-all category. Just realize that maybe they're not meeting clear-cut criteria for PTSD or adjustment disorder. We have this other option that we can use. I use it quite a bit because in the military, just because of the way the system is there's a lot of money tied up in VA claims, and there's a lot of money tied up into PTSD. So a lot of times I see a lot of people coming for this disorder, but they don't necessarily meet criteria, but they are having like the flavor of it. I'll use this specifier on there, or this diagnosis. So disassociation versus derealization. There is a difference between the two. It's kind of unique the way patients talk and present with this. And it's a specifier for PTSD. So it's not its own disorder. It's a specifier that you all would include in there. Derealization, the best way I can kind of describe that is you're essentially watching yourself in third person. That is derealization. You recognize the person, you recognize them going through the motions, but you're not necessarily making that connection that it's you, right? Whereas depersonalization, when I've had people describe this, they'll describe it as like walking through a fog. Like they know where they're going, they know what they're doing, but it's kind of very, very, they're slow or it's very kind of clouded. I've also had patients describe it as like trying to walk or do something through water, right? You're meeting a lot of resistance. That's kind of depersonalization. Patients always kind of describe it in a unique way, and you definitely will encounter it. So, PTSD. Big one with this is realize that it has to be greater than 1 month, right? If it's less than that, it's acute stress reaction. It's a very different diagnosis. So it has to be at least 1 month, but you'll notice that there's no end time to it, right? So, as let's say had an event, it's been 6 years, and now all of a sudden those symptoms are coming up, that still meets criteria for PTSD, right? And if their symptoms never resolved and never went away, and it's been 7, 12 years, that's still PTSD. We don't put an end cap on it. We just have this one time frame specifier that's on there. PTSD, especially from the military population, everybody thinks that it's tied to combat, and combat can definitely cause PTSD, but just realize you're more likely to encounter it from one of these other conditions, right? When you're talking about PTSD, the more personal the violence, the more likely you are to develop PTSD. That's why we have such a huge number of it in sexual violence. Sexual violence definitely causes PTSD. It's a very personal event, it's very intimate that happens, a lot of times that person feels violated, right? That's what we're talking through with that one. Witness violence to family or friends, again, depending on where you grew up, what happened to your family, if it was something traumatic and bad and you saw it, increases your likelihood for PTSD more than the other ones. Violence towards self, that's like suicides and things like that. Exposure to organized violence, that is that 3% up here. That is military. So that is actual combat related. You're causing the violence, you're doing it on purpose, and it's organized, right? So yes, it exists. Yes, PTSD is a military diagnosis. We care a lot about it. We put a lot of funding into it, and we're commonly associated with it, but we're making up only a very small majority of the actual stuff that goes on with that, right? So when you're talking about your screener forms, there's a ton of different screener forms that are out there. It depends what you have access to, because some of them are tied to money, so they're behind the paywall because that institution has made it proprietary. Anything that's done by the VA usually has a lot of good data behind it. The VA's put a lot of money into this. And that's your PCSD 5. If you're a primary care and you need a good screener, that's probably the best one that's out there, right? It's very basic, it's not super in-depth, you don't need a ton of training to know how to use it, and it's very self-explanatory to the patient. So this is your PTSD, or your PC screener. So it starts off with this initial question, and it actually tells patients what actually counts as a traumatic event, right? And it gives you good examples of that. So now your patient can not just say like, oh, I don't know, at one time somebody yelled at me. Like, that's not PTSD, it has to be a traumatic event. And it gives them examples, right? Then they just simply answer yes or no. That's it. And when you're looking at your criteria, this actually satisfies the very first bucket that has to be filled, right? It has to be a traumatic event. Then it actually goes into the rest of the criteria. And again, it's simply a yes or a no. So a patient can fill this out, it's pretty self-explanatory, and it's super easy for you as a provider to know how to interpret that, right? So again, I'm not going to test you guys on the screeners. I may include it in the scenario just to say like, hey, they screened positive on this form. But I'm not going to expect you to know that. As you guys go out into phase 2, you actually start practicing. If you need forums, stuff to help you out, this is the one. That's why it's in. That's the one I recommend. Okay. So diagnostic criteria. So the very first bucket that has to be filled is bucket A, and you have to have an actual or threatened death or serious injury, right? There has to be a traumatic event. If there's not a traumatic event, they don't move on. It does not become PTSD. It can be something else entirely. It has to have a traumatic event type to it, right? Now, we keep that kind of relatively vague. When you're looking at the data, most people are going to experience a traumatic event in your lifetime, right? That's just kind of part of being alive. People die. Bad things happen. That's a traumatic event. However, only about 10 to 15% are actually going to go on to develop PTSD. So while it is out there, it's not everyone. It's not like you get exposed to a car accident and all of a sudden you develop PTSD. A lot of us have healthy coping mechanisms. We have family, we have friends. You can kind of get that group support and never kind of experience that. Also, criteria A4. So this cannot just be exposed to like news or watch a movie and all of a sudden they're complaining about these symptoms. That's not PTSD. They actually have to live it and experience it. There is a caveat to that, right? Anybody who works with electronic devices as part of their job and they're experiencing this stuff, that can be criteria for PTSD, right? So now you're thinking, a good example in Air Force is our drone operators, right? So drone operators, they make it their job to just follow people around with a camera, and now all of a sudden you're witnessing people have their life ended, right? And you're following them with that camera. That can lead to PTSD, right? Another good example that I've seen is if you're working the border and you're following these groups of people as they're trying to cross the border, sometimes bad things happen during those border crossings. People die, people get killed, people get arrested, and you're witnessing that over and over again. That can still meet criteria for PTSD because yes, you're doing it through a camera, but it's part of your job that you're being exposed to it. So now that they can still meet that criteria, right? Number 3, so learning that the traumatic event occurred to a close family member or close friend. The one that I'll see with this is suicide. So the family member is off doing something else, and then they get that phone call, hey, so-and-so is dead, they killed themselves. That can be very traumatic for that individual, especially if it's a very close connection. Remember, the more intimate the violence, the higher the likelihood of developing PTSD. If it's very impersonal, less likely. Okay? That's your first bucket that has to be filled. Next bucket is you need to have at least one of these, and that's your intrusive symptoms. So that is essentially reliving the event, right? That can be with, a lot of times I'll see with dreams or flashbacks, is where we see that a lot. And a lot of times what's causing it is something in the environment is bringing them back to it. Those intrusive thoughts are coming back and it's replaying over and over again. Trying to think of a good case for you all to have that as an example. We were taking care of a patient. They were on the RTD for, so it was for substance abuse. They were an alcoholic. The triggering event was he was on patrol, and I think it was Afghanistan. And he was the platoon leader, and they were on patrol. They were moving through a wadi, or essentially a river, right? But all of a sudden, they were in their full kit. One of his people stepped into a hole, sank immediately to the bottom, right? Drowned, died right then and there while they were on patrol. He, as a team leader, was responsible for that individual, and he was never able to kind of move past that. And now, anytime he would have these memories and flashbacks, the person was visiting in their dreams. So that was what was going on with him. We had a traumatic event, and he was having those intrusive thoughts that kept coming back over and over again and replaying themselves in the patient's mind, right? So next, if you have those intrusive thoughts, obviously you're going to want to do something to not have them. So now it moves into avoidance, right? So now you're trying to avoid ever having it. So now instead of going out and interacting with people, you kind of go away and you live on your 5 acres of land in the middle of Texas and never talk with anyone, right? I see that quite a bit. Or you start to avoid places, events, things that are going to bring you back and snap you back into those moments. You avoid them completely. So another good example, I was taking care of a patient on the inpatient floor. She was a basic trainee, and she had really bad PTSD. She was abused by her family and her boyfriend. And the family backed the boyfriend instead of the patient, right? So again, now you also have your family going against you. They were also in a very, very, very small town. You're talking, there was only one grocery store. There was maybe like 2 traffic lights. So everybody went to the exact same grocery store, and she still lived there. So what she had done was she had actually altered her habits to where she was no longer going to that grocery store. She would go at like the very end of night when they were ready to close, or would go very first thing in the morning, all because she was trying to avoid running into these people, and trying to avoid crowds and that would snap her back into what she had experienced when she was growing up. So now she's having this avoidance category. That's your next bucket that has to be filled. So a traumatic event, they have to be reliving it, and now they're doing something to avoid it, right? Next one, now this is where it's having an effect on you as an individual. This is your negative cognitive loop. So like we talked about when we were talking about the hero's journey, right? Most of us, we truly believe that the world is a good place, right? We always want the good guy to win. Good things happen to good people, right? Where that necessarily is not the case. And now, when something bad happens to you, you always have this positive outlook. How do you kind of reconcile that? And what happens is now it becomes the world is against me. The world is dark and evil. Everyone is out to get me. Everyone is out for themselves. That's where you see that negative mood. So you've actually had this complete switch, which again, is not the case. The world is shades of gray. When it becomes one of your predominant emotions, that's where it starts to become a disorder and a problem. That's what we see a lot with this. Okay? So this is that person that never make connections anymore. They don't really have friend groups. They fall away from their spouse and their kids. Right? That's where you start to see that divorce come into play because they just don't want to have a connection anymore. Important to remember aspects of the traumatic event. This is important. This is where you have to suss out and make sure that's not being caused by the TBI that they might have had, not being caused by drugs and alcohol. You always want to try and specify. That's where it can kind of become a little bit difficult. And also, persistent negative. So a lot of times they feel guilt. That's what I think when you're talking about PTSD is the biggest, not problem, but the darkest aspect of this disorder is these patients truly feel guilt and they feel responsible for what happened, right? If you're dealing with a patient who has sexual abuse history, a lot of times they're blaming themselves for being the victim of the sexual abuse. It's crazy what they do. And they'll basically say like, oh no, I did it, I deserved what happened to me, I shouldn't have dressed that way, or I shouldn't have been in that location. Or maybe if I just did a little bit extra, he would have been nicer to me, right? Or again, taking it back to the military, if I had been a better leader, this wouldn't have happened. Or if I had just found out what had happened, my buddy wouldn't have been shot. That guilt is really bad. And those patients will blame themselves, and it's the hardest part to treat, is to get somebody to recognize like, hey, you're not at fault. Nothing you could have done would have changed the scenario. And it's very difficult to get that. That's where you have to have two of these. So that's one more change that was in this category. You need to have two. Okay. So now we talked kind of that negative altercation. That's more in line with depression. Now that marked alterations. This is classically when you think about the movies, the news media, what you see on Facebook. When they want to portray a veteran with PTSD, this is always the category that they go to, right? Which is not necessarily true. You can have more depressive PTSD or you can have more anxious PTSD. It just depends on what are the majority of the symptoms. But you do have to have at least two of these, right? That's that person who always kind of sits with their back to the door, back to the wall, facing the door. They're always on the lookout, always scanning. They can't ever relax, right? They're always waiting for something bad to happen. This is that classic anxiety disorder response. That person, when they hear a loud bang or something like that, they duck and cover, right? Or they have an overly exaggerated response to whatever happens to that, right? And this is where, again, you can kind of see that overlap start to happen with anxiety. So they can't sleep anymore. They have problems with concentration. So again, this is why PTSD is that great mimicker. It looks like a lot of other disorders, but they're going to have symptoms that are scattered throughout. They're going to have multiple touch points within the DSM-5. Reckless or self-destructive behavior, you see that quite a bit. That's where essentially bad things happen. It's going to happen no matter what. I don't give a crap anymore. And now they start to dive into gambling. They start to dive into driving really fast down the highways at like 120 miles an hour. They don't necessarily care anymore if they live or die, which can be, again, hard to get a control of. This is another one I'll see is that high-risk drug use or high-risk sexual activity, right? Now they're having sex with a bunch of different partners and they don't really care what happens. They're not necessarily thinking long-term or thinking things through. Okay. So that's your mark operation. Last one, duration. So this is kind of like your little catch-all, because again, remember, can't be caused by something else. It has to have a traumatic event associated with it, and it can't be caused by a medication, right? You always kind of want to do your due diligence. And as a clinician, when you're actually practicing, this is where it can kind of become a little bit difficult, is because these patients a lot of times are self-medicating, whether that be with drugs, alcohol, lifestyle, and you're going to think, oh, this is just a run-of-the-mill alcohol use disorder, and it's going to cloud it. Because again, if it's caused by the alcohol, then it doesn't meet criteria for PTSD. But the alcohol can be how they're treating it. So you have to figure out what came first. And this is where I'll say, if you guys are dealing with a patient you think has PTSD, never be afraid to refer out. Right? That's what will definitely get us involved early. Let us make a clear diagnosis, especially if there's a lot of overlap with other things that are going on. So, specifiers, again, I'm not going to make you guys know specifiers for this disorder, but just realize there's three that are out there. So, depersonalization, derealization. I see this a lot if it happened to kids. Because when you're talking about a kid, when they're put in one of these traumatic events, they can't necessarily fight back, especially if your abuser is bigger than you, they're stronger than you, maybe it's a parental figure. You can't necessarily run away, you can't fight, right? So if you can't fight, you can't flee, what is your body going to do to protect itself? Well, it's going to basically cocoon your mind and shut everything off so that you're no longer living the scenario. Your body is living it, but your mind is not. It's a protective factor. So your body, as it's growing up, learned to use this mechanism to protect itself. So now whenever you turn to adulthood, whenever you have a stressful event that happens, you automatically snap back into that because that's how your body has learned to protect itself. So if I'm going to see these two specifiers, I tend to see it in people who had a lot of abuse or something bad happened in childhood, and it happened repetitively. That's usually where I'm going to see this, and now that's the protected medication that I'm having. I think I told you guys the story about the girl who was sold out by her parents for drugs. So she definitely actually had depersonalization. Like classic clear-cut example, when we were talking with her, figuring out what was going on, she would always kind of cocoon herself anytime life got stressful, which happens quite a bit. So we included this specifier on her. Right? So treatment, this is where you need to make sure you pay attention to your treatments because they are different, but they sound similar. So first one is cognitive processing therapy, CPT, not to be confused with cognitive behavioral therapy, CBT. It's an offshoot of it, but the treatment is different in that we're focusing on the traumatic event and we're helping that patient. Essentially, that memory is stuck in the mind. And what we're doing is basically helping them relive that traumatic event. That way, we can get it unstuck and it can process through. Right? That's essentially what therapy is doing. We have to make you relive the memory a lot of times, multiple times, so eventually you can process it, come to a resolution, and accept where it happened. Right? That's essentially exposure. So long exposure therapy, that's what that is we're exposing you to the event multiple times. Written exposure therapy is just a different offshoot of that. We're making you experience it multiple times. When you get your patient and you're telling them what's going on and you're prepping them for therapy, just warn them, do your due diligence. Therapy for trauma is not fun. Because again, I'm making you relive the worst moment of your life over and over again so that we can get it unstuck. Warning that patient ahead of time of what to expect can help them, especially because a lot of times they drop out of therapy and they won't ever finish because of how rough it can be. So that's where medications come in handy that can help make therapy even more effective, right? So medications, we only have two, if you guys remember correctly, that are FDA approved for PTSD. First one, Zoloft, next one, Paxil, right? Those ones actually have the FDA indication. So if you have to pick one to start with, you try and use one of these because they actually have that indication. For you all at primary care, if you want to know where to start with the FDA approvals. And then once that fails, you can start to go with that off-label use, right? That being said, all of these meds can work. And it's just kind of got to tailor it to the patient. Pick which one they've tried in the past, which one they've had good responses to. Do they have a family or genetic component that I can use to kind of pick the correct one? That's what you kind of go with that. The one exception being escitalopram. I generally don't use these two when I'm actually working on PTSD just because the dose ranges, they don't go high enough. Lexapro, you're looking at like 20 milligrams, maybe 40. Citalopram cuts off at 40. A lot of times with PTSD, I have to take patients pretty high in order to get that effect. I don't use them as much when I'm working with the PTSD patient. Fluvoxamine, that's the one that we always forget about, but you can use it, right? And then SNRIs, generally the one we go to is venlafaxine. That has a lot of good data behind it when you're talking about PTSD. But like we talked about, that dosing, you have to make sure you're very exact with it because patients can have a lot of brain zap, withdrawal, if they're not very exact with that dosing, right? Other one, duloxetine is another one I've tended to favor a lot, especially if I'm dealing with a patient who has a lot of chronic pain. That medication can be super helpful in as well, right? I'm not going to expect you to know the dose ranges. That's just on there in case you guys are curious how we actually start to dose this and how wide you can get with them. I'm not going to expect you to know a dose range. I'm not going to test you on that. That's something as a clinician we'll have to know that. Okay? So this is kind of all our other categories. So first one, antipsychotics. We can definitely use antipsychotics, especially if it's really severe PTSD. At that level, that's more the psychiatric level. I wouldn't expect primary care to initiate that. Maybe if you have no resources available, or you might be managing it once we have them stabilized. But we can use our antipsychotics a lot of times in combination with our SSRIs. Big one on this list that you guys need to know is prazosin. Prazosin actually has an FDA approval. It is for the nightmares only. So those intrusive thoughts. If a lot of it revolves around nightmares and flashbacks, giving them the prazosin, that's where we're going to get the best benefit, right? Dosing it is kind of a pain in the butt because you can go all the way up to 40 or 60 milligrams. So I always start off low. You're going to start off at like 1 milligram. slowly bring them up, because what will happen, because again, it's a blood pressure med, you'll bottom them out, and then when they go to stand up in the morning, they can fall over and then they smack their head, right? You always have to warn your patient about the medication, how they're using it, and what to expect. And if that happens, don't cancel the med, just drop it back down. The other important thing to know with this is it's not going to get rid of the nightmares. It's not going to fix their PTSD. But what it will do is it'll lessen it. So instead of having 5 or 6 nightmares in 1 week, now all of a sudden we drop it down, maybe they're only having 1 or 2. So it offers an improvement, but it's never going to fix the problem. Last 2 on there, these are kind of other therapies that are out there that you're going to hear about. EMDR is a big one. EMDR is an actual procedure that we do, and essentially what you're doing is you're moving your finger back and forth, and the patient follows it with their eyes, and it mimics how your brain acts in REM sleep. And what we've shown is when your brain goes into REM, it actually starts to do a lot of memory consolidation. So if I can mimic that with my finger while you're awake, and I essentially start talking with you about your trauma the entire time you're following the finger, and we kind of run through those events, and a lot of times it can help consolidate that memory, get it moved into long-term storage where it needs to be. That's kind of the down and dirty of EMDR. There's a little bit more to it. Another plug for psychiatry. So the psychiatry PAs that are coming out of FAMC, if you guys ever decide to go on to that LVAT, we're getting them trained in EMDR, so they're actually able to practice it in the primary care side. Last one, still a gangling block. This one, when you guys are working with patients who has PTSD and like they're maxed out on meds, they failed multiples, and you're like, man, what else can I do for this person? An SGB can be very, very helpful. One caveat to that is, it's not going to do anything for depressive symptoms, right? So if they're predominantly coming from that negative alterations, SGB is not going to do anything. But if they're predominantly from that irritability, that anger, those anxieties, this can be a really good resource to get control of that, right? So the best way I've heard it explained was essentially if you're going down the highway at 100 miles an hour, get in the SGB, get to an off ramp. It drops your speed down to 45 miles an hour. So you actually can deal with life that's going on around you. That's how you can use the SGB. The only one that I'm necessarily going to test you on in this is really this. Like you guys have to know this. This other stuff is for you when you become a clinician. There's more options that are out there. Right? This is from the original slide deck. So if you guys downloaded the old slide deck and you're using it to study, the information is relatively the same. I just didn't like the way that that was set up. So I kind of put my newer slides in there just to kind of help me with going through and talking about it. Otherwise, like the diagnostic criteria doesn't change. The meds don't really change too much, right? Trazodone, you're only using this for the sleep. It's not doing anything for their PTSD. So kind of keep that in mind when you're talking with them. If they have a lot of insomnia, we're trying to get something to get them here. Same thing with propranolol, clonidine. That's really only those hyperarousal, because again, they're blood pressure meds. But just realize these ones are not approved for the nightmares. So if I'm using these, plus I got them on an SSRI, plus maybe they have hypertension, and now I'm treating them with prazosin, stacking all those meds on top, you can really bottom somebody out. So you have to be careful when you're doing polypharmacy with these patients. Okay? Propranolol, interestingly enough, the way I'll use this one, because trauma can be so bad, like the therapy can be so bad when you're going through it, they have a lot of anticipatory anxiety about it. I'll actually tell them like, hey, here's propranolol, go ahead and take it 30 minutes, 45 minutes before you go in for your therapy session. A lot of times it lessens that anxiety that they're experiencing while they're sitting out in the parking lot. So they'll actually go into their therapy session, they'll actually get better. So that's how I'll use that. It's kind of like as needed before the therapy session. And there's some interesting data that actually helps with memory consolidation and makes our therapy more effective. Very small randomized controlled trials, but there's stuff that's out there. Benzos, I don't use them. I really don't use them in PTSD patients because I'm already dealing with somebody who has a lot of really bad trauma. They're at higher risk for a substance abuse disorder, so I tend not to use those. I'll try and use methadone or one of the other ones to get better control of it before I ever start to dip down in that world. But they do remain an option. They can be helpful. So adverse effects, again, this is pretty standard for all of the SSRI meds. You guys have seen this probably, 5 or 6 times now at this point. No major changes, nothing you would expect in that category. Yep. Good. This, I think I told you guys, this was removed from market because because of the liver failure. So you don't see that anymore. I guess you could probably still get it generic, but don't ever use that one. Right? Clonidine, this is another one. It's not going to treat their PTSD, but it can help with those symptoms. That's why we do use it in ADHD and kids as well. But just remember, you're messing around with the blood pressure, keep the bottom out. Alright, this is your pink box criteria for PTSD. It's a lot of slides that I'm going to click through real quick. I didn't like the way that it was set up, that's why I included those other slides, but I kept these in here just in case you wanted the pink box. You can kind of see that's a breakdown. There we go. Okay. Cool. So again, if you like the pink boxes, you definitely have those in there. Just remember, I have to fill each bucket before I can move on to the next one, right? And make sure you remember how the specifiers you have to have. The biggest thing I'll say is that they don't have that first traumatic event. They don't have PTSD. It's something else that's going on. You have to figure that out. Acronyms. If you like an acronym and you like memorizing those, this can be helpful. I've never seen this outside of IPAP, but having another acronym in your pocket if you like them never hurts, right? Good. That's your differential. Again, it can be a bunch of different things. It has a big kind of mimics a lot of different stuff. TBIs, if you have a TBI in the history that caused a traumatic event, it's almost a 50% increased risk for developing PTSD, right? So that patient has that history of getting a TBI when that traumatic event was happening. Just realize it increases that likelihood. It also makes treatment a lot more difficult. That's really where you want to load the boat. You want to get neuro involved. You want to get the TBI clinic if they have one involved. Psych involved because it becomes much more difficult to treat if that patient has a TBI history. Right? So that's PTSD. Before we jump into the other two, any questions about PTSD? Go into each one. Okay, cool. So this is acute stress reaction or acute stress disorder. This is essentially what happens immediately following a traumatic event, right? What I'll say with this is the symptoms look almost exactly the same as PTSD, but this happens less than 1 month. So you're talking like 2 to 3 weeks after an event, they might be having these symptoms. One thing I'll tell you guys as a provider is don't ever pathologize what essentially is a normal response to an abnormal event, right? Most of us getting into a car wreck is a traumatic event, and we have this abnormal response to it. You're supposed to have that response. You're not supposed to be cool and calm if your car wreck was bad, right? If your family member dies from suicide, it's normal to have a really exaggerated response to that. You want to tell that patient, like, hey, you're going through a normal response. This is what we would expect to happen. You don't necessarily need all these drugs and all these therapies. You don't want to pathologize it. The moment that you pathologize it, now they start to cling to that disorder, they cling to that diagnosis, and it becomes their personality. It becomes very difficult to treat. So, 3 days to 1 month after being exposed to that traumatic event, so remember your time frame is different. And this one tends to be predominantly the anxiety symptoms that we're going to see, that hypervigilance that you're going to see starting to come out of that, right? Rather than so much on the negative cognition side. So there you go. That's all. Again, when you're looking at that stuff, it sounds very similar to PTSD. You're seeing a lot of that same stuff popping up. It's just in a lot shorter time frame. And make sure you pay attention to your criteria 9 to the 14. So it tends to be a little bit higher. Because again, we don't want to pathologize what is essentially a normal response. So there's your pink box for it. Again, pretty straightforward. It sounds exactly the same as PTSD. Just again, that time frame is what's going to matter in this, right? Treatment-wise, biggest thing I'll say is you guys need to work if you're dealing with these patients and you catch them in that window. So especially like ER providers, you're more towards the front line, if you're at a time aid station, stuff like that, and you're seeing this stuff come in, that psychologic first aid, if you can nip this in the bud, then it's not going to go on to develop PTSD. And it's nothing crazy. If you guys know what a COST unit is, Combat Operational Stress Control, this is essentially what they do, we're starting to work with that patient, tell them that they're safe, let them know that, hey, this is a normal response, we expect this to happen, right? And then providing that emotional support. So a lot of times, they just need somebody to talk to about what happened, right? So let them do their speech, let them tell you what happened, let them walk through it, and then kind of reassure them, have that kind of compassion, that empathy to understand the position that they're in. You don't need to feel their emotions, but understand what's going on with them, right? And kind of provide that network. And then start to reinforce that social network. The moment somebody becomes isolated and alone, all of a sudden those symptoms start to become significantly worse. So tell them, hey, you have a peer. Hey, this is your social network. If you're military, get the command team on the phone. Get the command team to send in the platoon sergeant, platoon leader, squad leader, whoever it happens to be. Let this patient know that they're not alone. Start reinforcing those relationships. Start reinforcing that social network. It's going to lessen the likelihood of developing PTSD. Lastly, as far as like actual offense, sleep. A lot of times these patients, they're not going to sleep after it happens, right? This is where I'm okay with giving a short-term sleep aid, right? Your trazodone, your hydroxyzine, your Benadryl maybe. Benzo, plus or minus, right? We'll talk about that in sleep disorder. Get them some sleep. You want them to have 7 to 8 hours of sleep. Get them to sleep. That'll make a huge difference. Next, food. Get them to eat, right? Give them a hot meal. Help them kind of start to have those normal human beings we expect to have. Just feed them. You'll be surprised how much of a difference having somebody eat can make, right? Relationships, again, reinforcing that they're not going through this alone. Help them start to reach out to people. Actually sit with them and be like, hey, well, let's go ahead and give them a call. That way they know to expect you. Or let's have this person meet you here. Start reinforcing those relationships. And then lastly, again, this kind of goes through all our mental health disorders. We don't want them to just sit and do nothing. Try and get them outside, actively exercising, actively doing something. If you can, get them that sunlight, right? Vitamin D, it matters. That's your initial treatment when you're talking about acute stress reaction because we're trying to prevent them from going on to develop anxiety, depression, PTSD, right? If you have the resources and you think it's going to be severe, refer early to CBT, especially trauma-focused CBT. Just realize, depending on your resources, it sounds great, like, oh yeah, just send everyone to therapy, right? It can take 2 to 3 months to get in to see a therapist. So just kind of keep that in mind. Sometimes, depending on the resources you have available, it can take time. But that is a very good one. And again, exposure therapy, psychological debriefing, that's a lot of times you'll see that in the military and on the medical side. If you guys are responding to code, they try and do like a debrief at the end of that. Essentially, yes, you're looking for ways you can improve it and do better. You have to be careful that the session doesn't turn into that. But essentially, it's group therapy, right? You're walking the group through as a whole, allowing everybody to get better. That is essentially what psychological debriefing is. SSRIs, again, it takes 4 to 6 weeks for the medication to start working. So if you think this patient is going to need an SSRI, remember that if it's over 1 month, it turns into PTSD. So you have to start it early. So if you think you're going to need it, start it early, right? Propranolol, again, if you're dealing with like a lot of anxiety symptoms, situational, this needs some help calming down, that can be a good option. Morphine, if there was an accident that caused a lot of pain, yes, getting that pain control can be helpful. That's where ketamine. Not the biggest fan of ketamine from the mental health side, but it has a benefit of being that amnestic effect. So if I can get that early on, sometimes it can help. If we can get pain control and a traumatic event, it can help prevent them from having long-term injury. When your patient comes in stressed out, just don't immediately start injecting morphine and put them to sleep. You need them to talk and process everything. But those things work to kind of get control of the events. Right? So that's acute stress disorder. Again, very similar to PTSD. Focus on those time frames and just realize the biggest thing, this takeaway for you guys to become clinicians, don't pathologize what is a normal response to abnormal events. Okay? So adjustment disorder. So this is the one condition where I will test you and I expect you to know the specifiers, right? And here's the reason why. This is the #1 diagnosis that we see in the military, right? When you're looking at the diagnostic conditions, this is not over, but I think it's right at 50% of the mental health disorders are adjustment disorders. When you join the military, and you don't like the military, it now becomes adjustment disorder, essentially, right? Like we can cause it in anyone. Okay. So with this one, the biggest thing is they have a significant event, and then within 3 months, they now develop all these other symptoms. That now becomes adjustment disorder. It doesn't necessarily have to be a traumatic event. Now, if it's traumatic, it's more in line with PTSD, but it's just something that happened in their life. They were perfectly fine until the event happened, and now after the event, they have all these symptoms. So if you're thinking about things in your life, joining the military, right? You think the military is going to be awesome, and you think you're going to be a cook, and you're not going to have to go out to the field. Now all of a sudden you find out, like, oh crap, I have to do all this other stuff. Now it turns into adjustment disorder, right? If you go to a job that you don't like, you have to keep working it, and now all of a sudden these symptoms start. It becomes adjustment disorder. If you go off to college, and you're in college, and all of a sudden you don't like the way college is going, you have all these symptoms pop up. It becomes adjustment disorder. So this one, there's always going to be an event that immediately precedes whatever their symptoms are. And then, with PTSD, I can't remove your trauma, right? With adjustment disorder, if I remove the stressor, all your symptoms go away. So, if I just kick you out of the military was the big stressor for it, and you get better, that's adjustment disorder, right? If I find you a new job where you're not as stressed as much and your symptoms get better, that's adjustment disorder. With this one, the big difference is that when I remove the stressor, your symptoms are expected to improve. That's how we can kind of differentiate the two, right? So again, that's where you can see that bottom, resolving after 6 months. That's one of the big differences. So that's where with treatment, we don't necessarily want to jump straight into meds with these patients because it's not necessarily a psychiatric condition, it's a life event that's causing a lot of stuff. We still use the meds, they can still be helpful, especially if you can't get rid of the stressor, but they're not the primary treatment. So these are all your symptoms that you're going to have that pop up. So market distress out of proportion to the event, right? Most of us, if we get a bad job, we're going to be able to deal with it, right? But if all of a sudden you're way out of proportion, now you're missing work, you're skipping school, you're doing drugs because of the event, now it becomes an adjustment disorder, right? So this is why I want you guys to know the specifier, because adjustment disorder, it can present as almost any mental health condition. It can be depression, it can be anxiety, it can be trauma, it can be substance abuse. The difference is once I remove that stressor, they're going to get better, right? So if they're classically presenting as MDD, but they were perfectly fine until something happened, now it becomes adjustment disorder with major depressive disorder. That now becomes specified, right? If they have a lot of worry about how they're going to perform in class, and they're worried about their future if they fail tests, they're worried about their GPA and it's overwhelming, and it all started with a particular class or when they went to college or went to school, now it becomes adjustment disorder with anxiety, right? So these specifiers are going to be important for you all as military providers because, and it's where I'm going to hop on my soapbox real quick, if I make the diagnosis of MDD or I make the diagnosis of generalized anxiety disorder and that patient does not get better, now that becomes an MDD. Right? Because that is an actual disorder, they now have to get disability for it. If I diagnose them with adjustment disorder, well, I'm basically saying, like, hey, they're stressed, they have all these symptoms going on, because it's the military. That doesn't necessarily meet criteria for an MED, right? Because once I kick them out, all their symptoms are going to resolve. So you have to make sure that you're using the correct diagnosis, and if they are presenting with depressive, anxiety, whatever it happens to be, throw on the specifier. That will make your life easier as a clinician, right? With disturbance of conduct, so I have a good story with this. All right, so I had a patient, a young guy, he was a 68 whiskey from down the hill, and he did not like the military. He wanted out. But the Army, in our infinite wisdom, basically said, yeah, you're not leaving. You're going to finish AIT, and you're going to go on to your next duty station because numbers matter. And they would not let this guy chapter out. They wouldn't do a family SEP, they wouldn't do a 517. They would not administratively separate this guy. So he was just stuck at AIT. He could not leave. He was going to behavioral health, and we're like, yeah, he has adjustment disorder because he's in AIT. It had progressed to the point where he had concocted a plan with his roommate that he was essentially going to fake a suicide attempt in order to get chapter out. Because if you're suicidal, now all of a sudden that bar to separation becomes a lot lower. If you're suicidal in AIT, the chances of you being able to complete 4 years of service and deploy with agency are a lot lower, right? So we tend to chapter those people up. So as we're talking with them, getting the history of what's going on, first off, his story didn't quite add up. Because apparently they had all went to Chow, they marched to Chow, but nobody bothered to do accountability for him. So that's one that's super weird. The Army's all about accountability. And then two, when they found him, he was in his closet and he was bleeding down his arm. Which you're like, okay, that sounds like he had an attempt. But when you're doing the physical exam and we're looking at his arm, he had scratches all over his arm in multiple different locations, right? That's not consistent with somebody who has a suicide attempt, right? If you're trying to kill yourself by cutting, it's very precise and it's very exact. They know what they're doing. You're doing longitudinal cuts up the arm, right? His was basically very superficial scratches. He was never going deep enough to hit an artery. And it was on the top of his arm, on the bottom of his arm, on the forearm, like everywhere, right? So again, the injury pattern is not adding up to the story. So essentially, as we're talking with them, pointing all of this stuff out, they're like, hey, we're going to call command and we're going to get some more information. Finally, he broke and he's like, okay. So me and my buddy, I basically said I was going to commit suicide. I was going to hide in my closet and I was going to cut myself with trauma shears. They're like, okay. He's like, it was so painful that I just stopped. I just scratched myself with it, right? So now it sounds funny that technically it's malingering, right? Because now he's injuring himself to get out of duty. But the primary factor was he was just so exhausted and done with the military and nobody was letting him leave that he was willing to go through these huge lengths and now the legal repercussions of faking a suicide attempt just to get out of the military. So that's where you can kind of start to make that specifier with disturbance of conduct, right? So if you're dealing with a case where you think it's malingering, when you think the patient's faking to get out of something, you can actually, if you're meeting criteria, you can make a diagnosis of adjustment disorder and slap on the specifier with misconduct disorder, right? And now you can make that specifier. Now we can have some ammunition we can work with. Malingering, yes, technically it's punishable under UCMJ, but I've only successfully seen 2 cases where we're actually able to say it's malingering, right? It's very difficult. All right. So treatment-wise, again, we're primary. Yeah.
So this is, we're only going to see this in centers like post.
Oh no, they can develop it at any point in time. Again, all that happens is there has to be a significant event, and the symptoms start 3 months after that, right? So it can be really anything that's stressful in a person's life. It can be a marriage, it can be a divorce, it can be a new duty station, it can be a new command team. I'll see this actually, since you asked, there's kind of 2 points in life where I'll see adjustment disorder. First, when you first join the military, because it's a lot, right? The other time I'll see it is when people are getting ready to separate out. Because now you're a bigwig, right? You're a colonel, you're a sergeant major. The military is your life. That is your identity. And now you're leaving what is essentially your identity. They have a hard time adjusting to that and going to the civilian sector. You'll see it then as well as the retirement is the cost. And now it becomes adjustment. Did I answer your question? Yeah. So again, the biggest question with this is there's some sort of event that happened, and now all the symptoms started shortly after that. And once I remove that event or it goes past, now all of a sudden they're better. Okay? So treatment-wise, like we talked about, we really kind of focusing on stress reduction techniques, any sort of therapy, CBT, if you want to clog up the system. We try and generally treat this more with like MFLAC, with all those other resources rather than sending them full on to CBT, inpatient, or anything like that. But it can quickly rise to that level if it's not got control of. Medications, again, we don't necessarily like SSRIs for this because it kind of pathologizes and reinforces that there's something wrong with the person. And in theory, if I can remove that stressor or lessen the stressor, they're actually going to get better, in which case my medications are not going to fix your marriage, right? My medications are not going to fix your job. My medications are not going to help you retire or help you integrate in the military. Meds don't do that. So it's kind of really important to reinforce that to your patients that you're actually working with them, right? All right, so kind of that quick down and dirty PTSD, if you had to kind of suss out these 3, that's your big 3 that are kind of separating them apart, right? So again, traumatic event makes it PTSD. Traumatic event less than 1 month makes it acute stress reaction, acute stress disorder. Something happens that's stressful, now it becomes adjustment disorder, right? So, and I kind of skipped over this with the PTSD section because in primary care wouldn't be expected to know it, but there's a lot of data that's coming out now about like MDMA, psilocybin, and stuff like that. If ever you guys wanted to know more about kind of the research that's going on and whether it's going to be good or not, these 3 podcasts who's all from the same site, are pretty good. They kind of do a deep dive into LSD and MDMA and into psilocybin, right? They're pretty good if you want to know more. Otherwise, what questions do I have about stress reaction, stress factor? Going once, twice, 3 times. Right, that's all I got for y'all.